Moving into hyperventilation, the true definition of hyperventilation is when the minute volume actually exceeds the metabolic demand. The patient is blowing off too much CO2, which actually is going to start decreasing the pH of our patient, and then the result of this is actually some kind of oxygen starvation, leading into some kind of altermentation as well. And because of the oxygen starvation, there's going to be a reduced blood flow to our actual cranial vault. So symptoms, they're going to be pretty stressed out. They could be going to a panic attack. Numbness around the lips, okay, numbness to the nose, numbness to the face. You're going to get those carpal pedal spasms. If it's bad enough, they're going to faint. And remember, that's the brain's kind of Control-Alt-Delete function to the brain's getting upset because it's not getting the good cerebral blood flow that it wants. It's not getting all the nutrients and oxygen for the energy consumption that it needs. So it kind of resets itself by making the patient pass out, and then hopefully the patient regains conscious again and they are breathing normally at that point. And they're going to have clear lung sounds with this. Usually you're not going to get any kind of adventitious lung sounds with a hyperventilation syndrome. Signs and symptoms, they're going to have the paresthesia, kind of the numbness and tingling in their face, the carpal pedal spasms. They can start becoming agitated or confused and possibly start feeling the actual effects of them blowing off too much CO2 and the decreased cerebral blood flow, so they are going to start getting dizzy, leading to that syncopal episode. Some more symptoms, they can have a sharp, non-reproducible chest pain, and that's just because of the fact that they're breathing so fast and their muscles are starting to become hypoxic. They're breathing too fast that they're not able to saturate their lungs with the saturate their red blood cells with the actual molecules that they need because it's not giving enough time, creating that pressure gradient in the actual lungs for true good diffusion. They can be having some kind of ECG changes, which with the hyperventilation syndrome, more than likely you're going to start seeing some PVCs happen just due to the fact that the actual red blood cells is not supplying everything that it's supposed to with the oxygen because it's not truly carrying the oxygen that it's supposed to be doing in the first place. Okay, so when we're talking about the actual treatment, let's put the patient in a position of comfort as best as possible. Let's try to coach the patient's breathing, okay, using some kind of de-escalation techniques. I think the big thing that we can do for these is definitely just get the patient out of the situation that they're in. You know, if they're in their house and maybe they got into a fight with a loved one or something like that, or they just received some bad news, let's get them out of that environment. Let's put them in the back of our ambulance, which is our office, and really kind of start trying to get the patient to calm down there. We want to take a really good history of the patient, just so that we can rule out anything else, such as like a PE or something like that. Remember, with a PE, your oxygen saturation levels are going to be low, no matter how many or how much oxygen you're going to give, where that hyperventilation syndrome is going to be usually right there at about 100%. We still want to do a 12 lead. Again, we're doing this to rule other things out, and we want to make sure that the heart is not getting too agitated when it comes down to it. This can really help us kind of gauge how our de-escalation techniques are working, and we want to monitor SpO2 and end-tidal CO2, and we do want to try to transport these patients. And I think the best way to justify that transport is to, one, get the patient out of the situation, and two, get them to the hospital to where they can actually talk or receive services, maybe possibly even psychological services or whatever, in order to help them manage their stressors a little bit better, to avoid them having to initiate EMS due to the hyperventilation syndrome in the first place. And I just noticed a typo on this last slide. We do not have the patients breathe into a paper bag anymore. I have no clue where that came from, guys. I'm sorry. Go ahead and scratch that. That does not work. That's an old wives' tale. I do want to say, though, is that don't write the patient off as just being another panic attack, okay? You don't want these patients to turn around and have a detrimental outcome to them because you believe that this was just a panic attack. These are good patients where if you guys do that, where you guys can actually lose your license, right? So you want to make sure that we're ruling out, taking a good history on our patients, listening to our patients, getting them out of that situation, and then providing the appropriate medical care, specifically getting them to the hospital so that they can talk to somebody about their stressors and see if they can actually maybe be prescribed some medicines for some anxiety or have other resources for them in order to deal with their stress. But there's a lot of disease processes out there that can actually cause somebody to hyperventilate, and we want to make sure that we're not missing anything. So there's going to be a lot of rule out with these patients, and just make sure that you're checking all the boxes and covering all your bases on these guys. Guys, that's all I have for you on this. We covered pulmonary edema, CHF, pulmonary embolies, ARDS, and hyperventilation. So if you guys have any questions, as always, please make sure that you email me. Make sure that you guys are looking over your respiratory guidelines because I didn't spend too much time on treatment on these. Just kind of giving you a background of the actual disease processes themselves. And I will see you guys in the next lecture.